All right, so now we're going to talk a little bit about healthcare institutions. So what are healthcare institutions? They govern a population's health, diagnosis, treatment, and prevention of disease. So the delivery of healthcare is split into three different levels. So first we have primary care, which many would argue is the most important level of care. And that is the care team or provider that is responsible for preventative or ongoing care. So one of the biggest problems in lower socioeconomic communities, is that they don't have access to primary care. They don't really have a primary care physician that they trust, and that prevents them, from seeking care for diseases that could be prevented or diseases that need to be treated before it's too late. So that's primary care. Secondary care involves acute or emergency care, like if you go to the emergency room, or specialist care due to referrals. So if you go to your primary care, and there's a problem that they feel is outside of their scope, they'll refer you to a specialist to go see. So that would be considered secondary care. And then tertiary care is a specialized form of care for individuals that have a specific set of needs. So like if you go to a burn center for burns, or if you go to a specific, say, cancer hospital for if you have cancer, that would be considered tertiary care. It's a specific specialized institution. So the way we look at disease varies by culture. Again, we're talking about social constructs. Different culture may place more or less importance on different aspects of health. So one country you go to may put a lot of emphasis on mental health, and then another country you go to might think it's taboo to even talk about mental health. So many countries, for example, wouldn't consider ADHD as an illness. And medicalization is the process by which a condition is reconceptualized as a disease with a diagnosis and treatment. So there are some cultures, I remember reading that when their elders get old and they start showing symptoms of Alzheimer's, they don't really diagnose them with a disease because it's just part of the culture, and they just think that that is a part of growing old. So medicalization of that would be just the collective realization that it's not a normal part of aging, and the setup of a diagnosis and treatment in that local community. That is a good question. I don't remember what culture that was. I want to say it was, I don't think it was a Western culture, but I could definitely find that out and put it in the group me. So the two models of disease, the medical model of disease is a model that emphasizes the physical and medical factors as being the cause of an illness. So that's the pretty like hard scientific model. So the physical and medical factors, we're looking at if you're sick, why are you sick? If you have a heart condition, what specifically in your body is contributing to that heart condition? Do you have plaque buildup? Do you have this? The specific medical factors that are contributing to it. The social model of disease looks at disease through a social lens. So we're not just looking at our physical factors that are causing the disease. We're looking at the risk factors of our social life that put us at risk for these diseases. So a model that focuses on the effect of one's social class, employment status, neighborhood, and other social factors on one's health. So for example, if you're a construction worker, you may have a higher incidence of lung disease than someone who is working, an office job. So the social model of disease, we would look at those factors rather than looking directly into the person's lung and seeing, maybe scarred alveoli tissue or something like that. So it's just two different ways that we look at disease. It's sort of like the causes of the disease and maybe like the correlations. But I would argue that they're both pretty important. They're both important ways that we understand disease. So we're going to continue on with this. Social stratification very drastically affects healthcare, as I'm sure a bunch of you know. Low-income individuals often cannot afford healthy food, work multiple jobs, and have no time for exercise. They have limited time to sleep, and they are exposed to many stressors throughout the day. And this is also super evident with COVID-19. A lot of the essential workers, they're blue-collar jobs, they are lower-paid jobs, And a lot of these people we could see disproportionately affected by COVID-19 because of this. So that was very evident. Very low income areas where healthy, fresh food is hard to find because of the lack of grocery stores are known as food deserts. So this is why those low income areas are more likely to eat high calorie foods with low nutritional value. So you're not going to find a Whole Foods, but you may find a McDonald's. And there is a higher rate of obesity among those impoverished in America, at least. But yeah, it's just because they can't really afford organic food. They can't really even afford fresh food at all, or they have trouble locating it because it's too far. Okay, and then a little bit more on the sociology of sickness. We have this concept called the sick role. It was developed by Talcott Parsons. And it's a concept that describes how society reacts to an ill person not being able to contribute to society temporarily. So if you just take off of work for a week for no good reason, you just want to sit around. If you don't have the best relationship with your coworkers, they might not be so apt to help you. They might not want to cover for you when you're there. If you're just taking off, you say, screw you, and you leave, they're not going to want to cover for you. But because of this sick role, Parsons said, if the others can consider this illness legitimate, they're going to exempt you from that deviance. They won't consider you deviant because the sickness is not your fault. So they will excuse you from your normal social roles and they will cover for you. This, however, doesn't always hold up empirically, because sometimes for chronic diseases, people have to go through struggling. They have to continue their daily life. Stigmatized diseases, people probably will not confer the sick role to those who catch a stigmatized disease, say an STD, for example. If you catch an STD and it is debilitating to you and you can't go to work for one day, certain people might not be as empathetic to you and they might not cast the sick role on you and allow you to be exempt from your work just because they feel it's not legitimate. And it's the same thing with little known diseases. If you're not familiar with what the disease that the person has is, you again may not cast them the sick role because you're not familiar. You might think they're faking it. You might think they're exaggerating their symptoms. So you're not going to let them off the hook, basically. And the illness experience basically just takes into account the patient's subjective experience of the illness. So instead of looking at how other people treat us when we're sick, the illness experience is just how we experience it. So it's concerned with the meanings that we give our illness and how it affects our daily lives. So how it affects our roles throughout the day. If you catch COVID-19, your life is going to change for 14 days. You're not going to be able to leave your house. And how does that affect you? How does that affect how you think about yourself? How does that affect how your friends think about you? That's basically what the illness experience is considering. But I'm going to start this question. A patient is referred to a pulmonologist to further examine his lung pain after working in a coal mine for years. He's now seeking which type of care? All right, so half of you said C and half of you said D. So the answer is secondary care. So a patient is referred to a pulmonologist to further examine his lung pain after working in a coal mine for years. He is now seeking which type of care? Palliative care is not one of the levels. It's just the type of care for those at the end of their life. Primary care would be if he goes to see his general practitioner. And that is probably how he was referred to a pulmonologist. But this would be considered secondary care because he is being referred to a pulmonologist. It would be considered tertiary care if he were going to an organization or a building that specializes in pulmonology or specializes in black lung from coal mines. So tertiary care is a lot more specialized, and it's usually a facility that's specialized for it. So like if you're from New York, think of Memorial Sloan Kettering is specialized for cancer. We said before, burn centers, those are specific places where people go instead of seeing a dermatologist for a burn. That would be secondary care. But if you went to a burn center, that would be tertiary care.